Might make a start, and it's my pleasure to welcome everyone to session 3 of the Psycho-oncology Cooperative Research Group's virtual scientific meeting this year. As you know, it's running over 6 days with 7 different sessions. So we're number 3, end of the first week, and just to let you know that we're recording the webinar today, and it will be available for viewing on the PoCoG YouTube channel post the meeting. And so thank you very much to Bonnie for doing that for us. And it is my pleasure to introduce myself. So I'm Associate Professor Haryana Dhillon, Behavioural Scientist at the University of Sydney and the Chair of PoCoG Scientific Advisory Committee, and also the lead of the BRAINS program of work, and I'll be chairing this session today. And I would like to acknowledge that I'm joining the webinar today from the lands of the Gadigal people, but I grew up on Gamilaroi lands where my home and my heart are. And I'd like to acknowledge the traditional custodians of the land and their long history for care and knowledge of the country for us to learn from. And I would like to pay respects to elders past and present, particularly for all of the tribal lands on which we're all of us are joining from today, and to also declare my support and commitment to young Aboriginal and Torres Strait Islander people as they grow and develop into the leaders of the future. And we have a fantastic range of speakers today, some presenting new data from projects that relate to the BRAINS program, and some talking about work that we are currently undertaking or about to start. And just to give you a little bit of background, the BRAINS program is funded by the MRFF, Brain Cancer Survivorship Mission, in the 2019 funding round. And what we have are 5 themes of work that cover patient support needs, information needs, caregivers, models of care, and interventions to support and reduce the impact of brain cancer on survivors and their families. So we'll hear from a range of speakers today, as I said, and I'd also like to acknowledge that this is a fantastic collaboration across 4 of the cooperative trials groups. So the COGNO, the cooperative group in neuro-oncology, the Cancer Symptom Trials group, and the Primary Care Cancer Collaborative Trials group as well, and with PoCoG leading the collaboration. So without further ado, I will introduce our first speaker, Associate Professor Joanne Shaw, who's going to be speaking to us about distress and unmet needs screening, how we're adapting the ADAPT portal for the needs of brain cancer patients. So Jo is a psycho-oncology and a health communication researcher with experience in developing and evaluating psychological interventions for people with cancer and their families. And she has she has expertise in developing and evaluating communication skills training for health professionals related to sensitive and emotional health professional patient interactions, such as breaking bad news or discussions related to mental health. And she's has a large body of research that's underway looking at models, quality and costs of evidence-based psycho-oncology interventions. So Jo, over to you.
Thanks, Harry. So I'm going to give a very brief presentation on the work on theme 1 of the BRAINS program, implementing needs assessment. So we all know brain cancer and its treatments causes major changes to patient function, social and emotional status. And these impacts actually extend beyond patients to caregivers. And so routine screening is one way that we can identify and need and facilitate appropriate referral. And so this work from for brain cancer really stems from PoCoG's work developing a clinical pathway for screening and management of anxiety and depression in cancer patients. And I know that many of you will be aware of this work, but the pathway actually provides evidence-based strategies for management of anxiety and depression, and has been implemented in 12 cancer services in New South Wales, participating in the ADAPT cluster randomised controlled trial. So the pathway uses the best available evidence to recommend screening, referral and management using clear treatment pathways based on symptom severity that can be tailored to the local referral networks and resources at centres and sites. And it's based on a step care model. So most intensive interventions are reserved for patients who require the most specialist need based on their symptoms. As part of the ADAPT program, we developed a series of complex algorithms to operationalize the pathway into an online portal. So the online portal is effectively a management system where we use validated online screening questionnaires to assess anxiety and depression. It involves alerts to health professionals when anxiety and depression is elevated in patients. And it uses the evidence-based step care management recommendations and referral templates to guide clinicians in their decision-making around treatment. So the recommendations around treatment are not only based on the referral options recommended from the literature, but can be tailored to managing the locally available resources. And so what we're planning to do for BRAINS is to maintain the anxiety and depression clinical pathway and add in a separate pathway for unmet need. And so all patients will screen using the distress thermometer. All patients will complete the brain cancer specific unmet needs survey, but those patients with high anxiety and depression will also be seamlessly directed to complete the HADS. The portal will use the algorithms to allocate patients to steps based on both their anxiety and depression and their unmet needs scores. And then the pathway triage conversation with clinicians and the referrals will seamlessly be facilitated through the portal. So when thinking about what we need to do to change the current portal to be brain specific, if we think about from a patient perspective, for brain cancer patients, we're incorporating greater accessibility options. So text to speech options. We need to update all of the information that is currently available around anxiety and depression to include unmet needs screening. And in a later phase of the portal development, we will also put a second portal access for caregivers. And so we'll link caregivers to patients and also have the flexibility for caregivers to screen independent of the patient. From a health professional perspective, we need to think about the algorithms for unmet need. And we're sort of working towards a step care model based on no need, some need, and high need. We're thinking about how do we actually prioritize anxiety and depression versus unmet need, and thinking maybe we need to think about the top 3 needs, or how we're going to streamline the alert system for clinicians. And we're in the process of actually developing a brain cancer specific pathway as part of the larger BRAINS collaboration. And this pathway also needs to take into account the caregiver need. So the other aspect that we need to think about is, unlike the ADAPT pathway, which is primarily hospital-based, we need to think about incorporating NGOs as clinics or institutions who are likely to use the portal. So thinking through how that will work. So development of the portal for BRAINS is really an iterative process to ensure that the system is aligned with the needs of brain cancer patients, caregivers, and the care team workflow practices. And so what we're aiming to do is to develop the clinical pathway and provide useful, usable, and sustainable system that will be rolled out nationally as part of BRAINS. All right, thank you.
Fantastic. Thank you, Jo. And I should have said at the beginning, my apologies, that if you have questions, please do type them into the Q&A box. You feel free to do that now, or if you are able to, if anyone on the panel wants to unmute and ask a question, please do. And I guess, Jo, I think that if I might just start, one of the challenges obviously is going to be developing the clinical pathway. Can you just tell us a little bit more about the process that PoCoG went through to develop the clinical pathway for anxiety and depression?
Yeah, so The clinical pathway for anxiety and depression was actually developed through extensive reviews of the literature to see what the most appropriate interventions, interventions recommended for different levels of anxiety and depression. And then we also conducted stakeholder interviews and a Delphi process to ensure that the pathway itself matched clinical practice in Australia. So if you think about a lot of the evidence is internationally based, and so we went through a lot of stakeholder engagement to identify that any areas or barriers that would impact on care delivery in Australia.
Fantastic, thanks for that. And I guess we had a whole webinar on Wednesday, which people are welcome to go back and view, that dealt with the development and the implementation and evaluation of the ADAPT portal and the clinical pathway in a cluster randomised controlled trial. What do you think are probably the most important learnings for us to take from that into the brain's work?
I think that the most important learning is that context is really important. Although we have, even with ADAPT, there was recognition that we needed to tailor the pathway to the local context. I think we need to think more carefully with brain cancer, because so much of brain cancer care is in a non-traditional hospital acute setting. So thinking through, how do we actually tailor the pathway so it meets the context in which care is delivered is really the key. And I think it may also be a little bit of an iterative process. And this is what happened with ADAPT, is we tailored it at a local level, but then when people started to use the pathway, we had to go back and revisit, because the workflows that we thought that we had captured were kind of the official workflows, but there were little breakdowns in workflow. And I think the other issue is it's really the small things that make the difference. So things like having someone that puts a slip of paper into a medical record, a paper medical record, or just those little tiny, often non-formal or informal practices need to be captured for these sorts of systems not to fall over.
Fantastic. So thank you for that. I believe my internet is just a little bit unstable at the moment. Hopefully it will settle down. We haven't had any questions posted in the Q&A box, so I think we might move on. And thanks. Brief overview of where we're going with the development of the screening portal for the BRAINS program. So it's now my to introduce Associate Professor Georgia Halkett. We'll be talking about the initial results of the CARE-IS trial, which was a randomised controlled trial of supportive educational interventions for patients, for carers of patients with high-grade glioma that was completed, and the analysis and detailed exploration of that data has been part of the BRAINS program. So Georgia is a senior research fellow who is currently supported by a Cancer Council West Australia research fellowship. She's based in the Curtin School of Nursing in the Faculty of Health Sciences at Curtin University, and in 2021 she became the inaugural cancer patient support program to Curtin's Health Innovation Research Institute. And we're delighted that she's been able to join us so early in the day. And I'm not sure if you're speaking at the moment, but you might have to unmute.
Yep, can you see my screen? All good?
Yes, we can.
Yes, okay, and you can hear me too? Yep.
Yes.
Thank you for the opportunity to present today. It's great to be part of the BRAINS project. And it's fantastic that there's so many themes and work happening in the area for brain cancer. So this is describing the Confidence to Care project, which is an RCT of a structured nurse-led home-based support and education for carers of people with high-grade glioma. And we had a fantastic team across the country working with us, initially funded by Cancer Australia funding, and now through the MRF BRAINS project. So high-grade glioma has a poor prognosis and is terminal and progresses quite quickly. the patients experience early physical and cognitive impairment, behavioural and personality changes. They're also legally restricted from driving and also have a reduced ability to work. So it has a big impact on patients right from the time of diagnosis. So the carers play a big role or vital role in supporting the patients throughout the journey from diagnosis. And we found in our initial work prior to this study that the carers were often more distressed than patients. And you can see in this graph, so we had 116 patients and 118 carers, and this demonstrates that the carers were more distressed than the patients from time one when they commenced chemoradiotherapy right through over a 6-month period. So this is why we were led to develop support, this current intervention to support carers to look after the patients and feel better prepared for caring. We also found that the carers have high unmet needs related to the distress around a range of things in terms of caring for the patients and also what sort of support they can provide and understanding the disease and also adjusting to the changes that are happening to the patients in terms of cognitive changes and personality changes as well. And there's currently in clinical, there's limited support currently available to carers. And so that is why we developed this intervention to add to the current clinical practice. So the aims of the CARES study, the primary aims were to improve carers' preparedness to care and also to reduce carer-related distress. And then a secondary aim was to look at unmet needs and carer strain. And we also are going to determine the healthcare costs related to the patient admissions, time in hospital, and healthcare resource utilisation. So looking at whether the carers are able to support the patients for longer at home and what other supports the carers are needing. So in terms of the intervention that we've provided to carers, first it started with a telephone assessment of their unmet needs by a trained neuro-oncology research nurse. The nurse also used a supportive and educational information resource folder, which was tailored to each of the individual carers as they went through. So they were provided information as needed, when needed, based on the assessments that the nurse did. And then there was a home visit where the nurse went out to the homes and provided face-to-face delivery of the education and the resource. And then ongoing telephone support monthly for 12 months, depending on what the carers needed and how the patient's disease progressed. So this is just a timeline of what that would look like. So the nurse telephone assessment was at the beginning, and then a home visit within a month of that, and then monthly phone calls, and the tailored information was provided to the carers over those 12 time points. And this is just describing what the carer resource folder had in it. And as I mentioned, it was tailored depending on what was flagged during the nursing assessments. And then the nurse would discuss this information in more detail with each of the carers. So the topics included dealing with diagnosis, caring for yourself, practical matters, communicating with relatives, and communicating with health providers. And then dealing with treatment, understanding physical symptoms and side effects, understanding mental and behavioural changes, lifestyle choices and complementary therapy, fertility and sexuality, and end of treatment, which talked also about palliative care. So some carers didn't receive the end of treatment information until it was relevant to them, and then other information wasn't sent out if it wasn't relevant as well. So we used a multi-state randomised controlled trial, recruiting participants in both WA and New South Wales. So the carers were recruited during the combined chemoradiation therapy for the patients. And the intervention was compared to usual care, which is provided through the hospital-based system. And the primary outcomes we were looking at were carer preparedness, measured using the preparedness for caregiving scale, and then carer distress measured using the distress thermometer. And the surveys were administered at baseline 8 weeks, 3, 6, and 12 months. And for the data analysis, we had intervention effects estimated using linear mixed models with fixed and random effects. And we looked at a time by group interaction. So this is just the consort diagram simplified, but you can see over time, so we started with 98 intervention and 90 in the control arm, and you can see over time there was quite a big drop off, and that was because the patients passed away or because the carers were impacted largely by what was happening with the patient and needed to drop out as well. This just demonstrates the patient demographics. And then looking at the carer demographics as well. So as I mentioned, we had 98 in the intervention group and 90 in the control group. And this is the main result. So looking at preparedness for caregiving, you can see that preparedness for caregiving improved for the intervention group, showing that the intervention was able to support the carers to understand and feel more prepared for looking after the patients. And you can see that that is a significant difference at each of the time points that were measured. So then looking at distress, unfortunately, there was no significant difference at the different time points, which is disappointing, but can be associated with the high impact that the disease has on the patients and the carers. This is just looking at what the nurse did. So when the nurse went through the each nurse telephone assessment, we recorded what she was discussing and what was covered. So the top 5 challenges or problems that the nurse identified included physical symptoms and side effects, dealing with treatment, caring for yourself, understanding mental and behavioural changes, and also practical matters. And then associated with that, the top 5 recommendations that were made were around accessing more of the resource manual and the information provided in it, accessing in-home supports, a referral to cancer counsel, referral to their general practitioner as well, and then also information from the Cancer Institute fact sheets. And then looking at referrals that the nurse made as a result of doing the nurse assessments, these included more in-home supports, including OT, for example, also social work, occupational therapist, appointments as well, general practitioner, and then also support from psychiatrist, psychologist, or a counsellor. So you can see that the nurse had a large role to play and many different things that needed to be covered within these nursing assessments to support the carer and also through that supporting the patient. So we are conducting ongoing analysis of the data. We've also done a survey of health professionals to describe what usual care looks like for patients and carers, and hopefully that will be out early next year. And we're, as well as doing the primary endpoints, we're also looking at carer unmet needs, caregiver competence and strain, and also quality of life. We're also looking at describing in more detail, as I just looked at briefly, the recommendations and referrals made by the intervention nurses and how that can be supported more, and what might be done in terms of supporting the carers more. We're also looking at a qualitative analysis of the preparedness to care data and what carers identified as what they needed help in preparing for. We're also going to look at case studies of particularly distressed carers. And we've also got a sample of AYA patients and carers that we can look at as a case study. We've got the health economic data as well. And we've also got data from those that were bereaved that we collected surveys from after, and looking at the impact on them and what supports they need as well. So in conclusion, the intervention that we used was effective in improving carer-supported, self-reported preparedness to care. Although carer distress was not reduced, that's potentially due to the debilitating and progressive nature of high-grade glioma and their ongoing caring responsibilities throughout the disease. So in terms of future research, which the Brains Project is building on as well, so we're looking at ways of implementing carer support into practice, and there'll be a number of presentations after me that's talking about that as well, and also looking at developing effective interventions to further reduce the carer's distress and support the patients. And thank you again for the opportunity to present it's been a large project with a lot of support and involvement from many different people. But thanks for the opportunity to present today.
Hi, everyone. Sorry, I dropped out there for a minute. I think, Jo, we've got a question that you were going to ask. Do you want to go ahead and ask your question?
Yes, thanks, Georgia. It's really interesting data. And my question is, in response to the lack of change in distress, and we saw exactly the same pattern in our Family Connect study with poor prognosis upper GI cancers a few years ago. Very similar levels of what the intervention was delivering, very much around the physical needs of supporting a patient. And my question really is, are we trying to change the wrong, or are we focusing on the wrong outcome? Maybe is it that caregivers are always going to be distressed, and so what we should be thinking about is our outcome measures being prevention of that distress, translating into more severe anxiety and depression. It's just a thought I've had for a while now, is like, maybe we can't actually reduce distress, but we can have a preventative effect on that impacting more severely.
Yeah, I think it's a thing that we can need to continue to consider, and it's I think it's good that we were able to change preparedness, and and there's other things that we can look at, like unmet needs and that sort of thing, but perhaps it's not, in terms of primary endpoints, maybe there's other things that we need to be looking at how we can modify, but yeah, definitely more discussion needs to happen. Yeah.
Fantastic. Thanks. Great question, Jo. We also had a question from Claire Cooper. So, Georgia, Claire's curious about how the decision was made as to when to send out end of treatment information. As you mentioned in your talk, it was varied. And was there the carer preference taken into account about how much information they wanted and when?
So in each nursing assessment over the monthly, so we did for the 12 months. So the nurse would judge how much information they needed and ask the carer whether they wanted information about end of treatment, or whether they needed that now, or whether they weren't ready. And some of them didn't want as much information as others, which is why it was important to tailor what was sent out, so it wasn't too much for them, and so that we weren't creating more anxiety, I guess. Mm-hmm. Yeah.
So I guess it really highlights the importance of making sure that whatever interventions around information and support are really tailored to the caregiver and the patient.
Yeah, and also screening unmet needs as you go, and looking at distress as you go as well.
Mm-hmm. Yeah, fantastic. So the another question this time from Mona Farris was, who wants to know what the uptake was like for nurse recommendations.
So we got some understanding of that from the follow-up phone calls that the nurse made to see where they were at as the time went over. So with some of them, it was needing to make the same recommendation as a follow-up, whereas others had made some changes and then needed more support in other areas. So it was good that we were able to continue to provide support over a period of time and see how they were going as well.
Fantastic. And I think, and Kerry Clover is curious to know if you have any sense of what the carer burden was, or if it differed by gender.
We still need to do that analysis. So I'll need to get back to you on that one. Yeah, but thank you for that question.
So I think the other thing that I just really wanted to highlight from this is it's a fantastic trial that you've completed, Georgia, and we're really lucky to have such detailed and rich data to be still analysing and exploring and really. So thank you for that, and thanks for the talk. We'll look forward to the papers and future presentations as they come out. So I'm going to move on now to presentation by Emma McDougall. So Emma is a PhD student, a PhD candidate at Curtin University, who's being supervised by Georgia and a number of other people who are involved in the BRAINS program. And Emma is focusing in her PhD on personality changes in people with brain cancer and what help they get. So she is going to give us a little bit of an overview of what she's been doing and what she's planning to do. So welcome, Emma, and thank you.
Thank you, Harry, and thank you everyone for the opportunity.
Can see and hear you.
Sorry, am I sharing the right screen?
Yes, it's all good.
Oh, great. Great. Yes, thank you for the opportunity to give a bit of an overview about my PhD project today. I'm looking at personality and behaviour changes in adults with a brain tumour and how patients and their carers can be best supported to manage these changes. So we know that personality and behaviour changes are relatively common among brain tumour patients. A systematic review estimated that up to 67% of patients experience these changes. However, it's likely that this is an underestimation due to the variability in how personality and behaviour changes are defined. For my PhD project, we're using the Diagnostic and Statistics Manual of Personality Changes due to a general medical condition, and that has specifiers around emotional lability, apathy, aggression or disinhibited behaviour. And the most common personality and behaviour changes that were reported in the literature are reduced motivation and changes to social functioning, irritability, and difficulties completing tasks. And the most distressing symptoms that carers reported for them in terms of changes in the patient were expressions of emotional lability, aggression, irritability, and changes to sleep and appetite. And personality and behaviour changes are quite complex to address due to the nature of these changes. Patients might have impacts on their insight or self-awareness and might not realise that these changes have occurred. And also due to the varied causes of personality and behaviour changes, they can be related to the tumour location or side effects from treatment or the psychological and emotional adjustment to receiving a diagnosis. So why is this research needed? Patients rated personality changes amongst the top 25% of their concerns. And we know that carers of adults with brain tumours report that personality and behaviour changes are a source of distress for them, and they feel unprepared or unable to manage personality and behaviour changes. And supporting carers in their role, it results in improved outcomes not only for the patient, but is protective against long-standing social and health complications for bereaved carers. And finally, if carers are overwhelmed or under-resourced, then it can result in hospital admissions, which increase healthcare costs and impacts patient quality of life. So this is a general overview snapshot of my PhD project. Firstly, conducting a scoping review to get a sense of the existing interventions that are out there targeted at managing personality and behaviour changes. And then the second study, I'll be looking at the carers interview data from the nurse telephone assessments to see within that cohort of participants what personality and behaviour changes were flagged at what time points and how they were managed by either the research nurse or the patient or the carer. And the final study, study 3, I'll be conducting interviews with health professionals, patients and carers. And I'll go into more detail about the aims of each study in the next slides. So the methods that have guided my PhD project is based on the MRC framework for developing an intervention. And my project is based in that point between the idea for an intervention and the formal pilot testing in the next phase. So these are the actions circled here, the kind of how-to steps that my project maps onto. So certainly involving stakeholders and consumers. We have some great consumers on board, and incorporating their feedback and input at each stage of the project. Yes. So my scoping review, we're in the final screening stages and write-up phase, and there'll be about 4 studies that met the final inclusion criteria. The main aims of this review is to summarise and to examine the characteristics of psychosocial interventions for personality and behaviour changes in adults with a brain tumour. And a secondary aim is to see if these interventions had any impact on outcomes for carers, whether it improved their experience of care or changed outcomes for them. And that's the search strategy we used there. Then study 2 is looking at the CARES trial, the supportive education intervention for carers of patients with high-grade glioma that Georgia presented. And I'll be looking at the nurse telephone assessments over the 12-month study enrolment period. These were recorded and can be transcribed, and so I'll be using thematic analysis to analyse these interviews. And the aims there are to explore what personality and behaviour changes occurred and the impact of these changes, as well as how they were managed or addressed by the research nurse, patient or carer, and finally exploring further what the perpetuating factors or contributing factors were to experiences of carer strain. And from initial data review, there's about a sample size of 30 participants. And my final study will be interviews with health professionals and patients and carers to explore what changes are the most distressing or impactful for family members, patients and carers. The second aim is to describe what current practice is, so how personality and behaviour changes are currently assessed and managed, the perceived efficacy of current interventions and what the gaps are in current management, and what are the unmet information needs as well. And the final aim will be to explore the barriers and facilitators of implementing interventions into clinical practice. And we're aiming to recruit around 15 to 20 participants in each cohort. And again, these will be semi-structured interviews and using thematic analysis. So the project anticipated outcomes, we're collaborating with some wonderful consumers already and seeking feedback on and input on the project from those with lived experience to guide this research. And we hope this project results in improved understanding of what interventions have been tested and further understand the research gaps and barriers to effective management of personality and behaviour changes, and finally to inform the development and testing of interventions that are targeted at managing tumour-related personality and behaviour changes. Thanks so much, everyone.
Lovely. Thank you so much, Emma. It's really important work and is definitely going to generate a lot more understanding in the brain cancer community around this particular very challenging problem that people are dealing with. Just a reminder to the participants to please add any questions into the Q&A and we'll ask them as we go through. But just to start us off, Helen's asked what's the scale that you're using to measure caregiver efficacy, self-efficacy, sorry.
When not looking at, I think this question's coming from the scoping review. So we were seeing just if the interventions that were included in the scoping review had any impact on carer outcomes. So whatever the intervention studies used to capture those outcomes, then they were included. So I don't know if that answers the question there, Helen, but thank you for your question.
Great. Okay, so in the interest of time, Emma, we might move on. Thank you very much for your presentation, and we're really going to be very excited about seeing the results of your study as it emerges over the course of the next few years. So it's a great topic to be undertaking. So now we'll move on now, and it's a pleasure to introduce Dr. Helen Hayden, who is a research fellow and registered psychologist working across a range of projects in research and consultancy arms of the Centre for Online Health, Centre for Health Services Research at the University of Queensland. Her passion is to increase access to healthcare using health technology, and she's particularly interested in using health technology to promote quality end-of-life care, and her larger projects focus on digital health interventions to promote quality of care in people with cancer, dementia, or life-limiting diagnosis and their carers. And so here Helen is going to update us on activity and progress around theme 4 of caring for the caregiver online intervention. So Helen, welcome.
Thank you, Haryana. Can you hear me?
Yes.
See my slides?
Yes,
lovely.
We can.
Okay, so hello everyone. So in this presentation, I'm going to give an overview drawing upon what George has already said in terms of how that then developed into the pilot of an online intervention of caring for the carer, and how it's now fed into theme 4 of the BRAINS program of research. But before I start, I would also like to extend an acknowledgement of the traditional custodians of the unceded land from which I'm presenting today, and that's the Yagara and Turrbal peoples. So our theme 4 team also includes Thea Blackler from QUT, Georgia, who you've just heard from before, and Anna Nowak from UWA. Okay. So I'll share the rationale for such an intervention, although it sounds like we've already heard very much about that in the last 2 presentations, and have a sneak preview of the evaluation results from the piloting of the Caring for the Carer website through to our next steps as we go from a fairly basic information-based website to further enhance it and make it more interactive as part of the MRFF program of work. And not to confuse you throughout, but sometimes I use the terms online intervention and website somewhat interchangeably. So going back to the beginning, we've heard about some of the issues that are faced by people who are caring for people with brain tumours, especially people with high-grade glioma. And so that evidence really shows and highlighting one of the unmet needs was around the struggle to get adequate support and reliable information. And that often also meant that people felt unprepared as they're thrown into this new demanding situation. But there was evidence, and as we've seen, there's evidence to suggest that providing reliable information in a timely manner and delivering carer-specific programs could help to alleviate somewhat the physical and psychological impacts on carers. But as Joe mentioned before, which was a really good point about it would be interesting to see some of the outcomes as well of this and what we're actually measuring, considering the nature of the illnesses and the demands on carers. So you've just heard from Georgia that to partially address those unmet needs in Western Australia, Georgia Halkett and Anna Nowak, along with a whole team of other people, developed Confidence to Care, that home-based education and support program. And this program, as Georgia said, was very effective in terms of increasing carer preparedness. But the team also at the time felt like it was important to explore whether that information should be delivered electronically to carers to extend the reach of it. And as such, the plan to translate the program to an online intervention was helped along when Danette Lang-Becker got some seed funding from the Sam Ryan Memorial Award, and the pilot project was born. And this is when I came on board. So in close consultation with 2 carer representatives, we started to translate and enhance the content from the Competence to Care resource manual that Georgia was talking about to make it more suitable for an online environment. So taking some of those topics, embellishing them. I sort of injected a little bit of my experience in terms of my psychological experience as well, working with people with life-limiting illnesses. And the care reps were providing feedback along the way. And part of that was, and potentially because of the scope and the limited funding that we had, that they said it should be focused on on high-grade gliomas only and not all brain tumours. So after months of work, our first iteration of the website was evaluated by a sample of carers from across Australia. You can see some of the topics there. And we're currently finalising the manuscript from these evaluation results, but our methods were threefold. We surveyed people prior to using the online intervention, and again, about 4 weeks after they had first logged on. We interviewed the users as well, and then tracked their use of the online intervention using Google Analytics. So sneak preview of the results. The Google Analytics showed that people spent most of their time on the websites, on the pages around understanding HGG and also how to support carer wellbeing, which to me then is indicative of people really needing that information too. Comparing pre and post user surveys, the only significant result was that depression dropped significantly. There was some decrease in anxiety and distress, and but none of these following results are significant. But while preparedness to care increased, what was unexpected was that carer competence actually decreased. So we'll really have a look at that in the main study from the BRAINS program. Assessment also showed that usability and acceptability of the website was high, and this finding is triangulated with the interview findings. So the interview findings really helped to highlight areas that needed improving in the website. Thematic analysis on the interviews was undertaken. People that were interviewed described many benefits of the online intervention and provided examples of how it helped them and also their extended family or the people around them. So for instance, some of the topics that they read about prompted discussions amongst families as well. So it was having an impact not just on the immediate carers, but also people around them. They described how it was useful to have reliable, trustworthy information all in the one place, because obviously everything we put up there was, we were making sure it was evidence-based. However, because it was the pilot, we really wanted to hone in on areas for improvement. So mainly this pertained to the visual design. One participant said, I don't think it's warm and inviting. Another said, I'd call it flat in its appearance. And they called for more videos and interactivity. And like we expected this sort of comment, these sorts of results, because we were on a very limited budget. And this is where we're really looking forward to enhancing the website in the current BRAINS research. But still in the pilot, we also got feedback that there was some greater depth of content needed to suit more experienced carers. And what I mean by that is that we had to sort of balance up what was realistic, because we found that our cohort of people that we were interviewing tended to be more experienced in terms of they were down the track. It wasn't, they sort of been caring for months rather than been looking after someone straight after a newly diagnosed cancer. And also some of them were health professionals. And I guess this is sort of exemplified because one person even asked for journal articles to be published on the website. So I'm not saying we're ruling any of that out. It's just that it's really in food for thought, because as we go forward with the MFF Brains program, we can start to make sure that we have got sort of a breadth of addressing a breadth of carer needs as well, where we can. From, I guess I have in my mind where you've got someone who potentially is coming home from having sitting with a partner, for example, just being diagnosed and having resources if they need it there, all the way through to if someone is needing palliation. So with the success of the MRFF brain funding, we're addressing the issues that were raised in the pilot. We've already changed the platform. We're starting to amend the visual design of the website and expanding the scope of the content. So now we're going to extend the scope to also include caring for people with low-grade gliomas as well. And a generous donation from one of the carer advisors has meant that we have been conducting some video interviews with carers so that they can give some examples, I guess, of their own lived experiences, and we're going to embed those in the new version of the website. So the plan for this current project evaluation is to determine the efficacy of the optimised website, to increase preparedness to care for people with brain cancer, and to assess the impact on carer distress, psychological health, supportive care needs, carer mastery, and carer clinician communication. This time we'll be conducting clinician focus groups or interviews to assess the usability and acceptance from the health professionals' perspectives, and to inform website development before we go ahead and recruit carers. And so this time we'll be aiming to for an increased sample size, hoping for 100 carers all up, as we do a waitlist controlled trial. So 50 participants can access the intervention immediately, and then the waitlist control will be 2 months after. So all will be given a baseline survey, assessing those things I just outlined in the aims, and then prior to the control group starting or having access to the intervention, we can post the, we'll administer the post or time to survey. So finally, our next steps: by the end of February, we should have videos completed, because they're currently being edited and embedded in the website, have addressed the pilot feedback to increase the scope and the content, and start recruiting. So please listen out for calls for help when recruitment time comes. Thank you.
Fantastic. Thank you so much, Helen. It's putting information on a website sounds like a very simple thing to do, but the more that you get into it, the more complex it seems to be. Yeah. And I just a reminder for the audience, please type your questions into the Q&A and we can ask them. But I was just wondering, going back to your pilot study, Helen, where you found that feelings of competence to care decreased, and I thought that was a really interesting finding. And would you be willing to speculate a little bit more on that, and as to what that might mean? Because I did certainly feel that perhaps providing more information also gave people a better sense of maybe what was ahead for them. Yeah, do you have any comments?
That's good thoughts. Actually, at one point when I was thinking about this presentation, I was actually going to field it with people in the audience as well, because it's slightly baffling. We're not quite sure why that might be. Happy to hear, and so that's an interesting suggestion. I think also in terms of what Jo was saying earlier about the distress assessment for people as well, is it on the similar vein of things, is because of the burden of looking after people or the stress that's involved, potentially it's affecting all of these things, including competence. I mean, is it a indicator of how people are maybe still, as different things arise going along, aren't necessarily feeling more competent as well? It's a pretty difficult task, I would believe, from where to go. So
okay, so stay tuned and watch the space, I think, is the answer, really, isn't it?
Yeah.
Jo, you've got a question, Jo Shaw.
Oh, I was just going to follow up on that, on your suggestion, Harry, that it could be that people have then got insight into what was to come. And just thinking about it from a pragmatic trial design, maybe assessing perceived competence over time, but on specific aspects. So if people say that they feel that their competence, their perceived competence has reduced based on the time at diagnosis, but then assessing retrospectively after that time, specifically around the time of early diagnosis and the utility of the website to provide information and support at that time, rather than just all across the entire time that people are accessing the website. Because I think what often happens is you give people information and they suddenly realize there's a whole lot of stuff that they didn't know. And so they say, oh, I'm really quite, I'm now feeling all at sea because I can't, I didn't realize I had to know all of this kind of stuff. But then over time, when they're reflecting back on their experiences, they realize that they actually found the information useful, but just not at the time of delivery. So I'm not sure that actually sounded quite coherent, but
I think you did, Jo, because I think Diane Legg has just commented as well in the Q&A that that her perception of it was potentially that caregivers becoming overwhelmed by information at the time that they accessed it was quite likely a problem.
Yeah. So they're really good thoughts, and we can make sure that we look at those as well. My only other thing with that, though, is I'm wondering, because the beauty of online interventions, I suppose, is that the person has control over where they're going. But yeah, that's still not to undermine what you're saying as well. And so it'll be interesting as well doing the RCT to see what comes from that.
And our final question for you, Helen, is from Kerry Clover, who asks if there is any direct interactivity with the people who are using the website. And I guess that is kind of getting at whether or not we've got live comment or connection during the interaction with the website.
So I believe that's something that I would like to progress in terms of even having a look at, do we get to the point where we're putting something like an online counselling or clinical thing on there. We have looked at a couple of things like the nurses interaction as well on there. But at the moment, the main thing in this very initial stages is also just about delayed, I guess, having notebooks and things like that. So where they can jot their own notes, but it's not so much a two-way interaction at this stage. But it's definitely, as our brains program and we all get together, is something that I definitely wanted to bring up and address.
Yeah, I think that's really important. So great question. Thanks, Kerry. And thank you, Helen. Really exciting to see this moving forward. But we might move on now to Professor Tamara Ownsworth. Tamara is a clinical neuropsychologist and with extensive experience in psychosocial intervention research for people with neurological disorders. She completed her PhD in 2001 and was awarded an NHMRC Public Health Postdoctoral Fellowship, and is now Professor at the School of Applied Psychology and leads the Neuroscience Aging and Dementia Group at the Menzies Health Institute of Queensland, and is Executive Editor of the Neuropsychological Rehab and past President of the Australasian Society for the Study of Brain Impairment. And Tamara is going to be speaking to us today about some work that has been ongoing for Tele-MAST, an intervention that's aimed to reduce psychological distress in people with brain cancer. So welcome, Tamara, and thank you for taking time out of your retreat to join us. Might just need to unmute.
Apologies, thank you. Thought I was so clever getting my talk up ready. Thank you very much for the opportunity to talk about survivorship and intervention research. So as Harry mentioned, I'm going to provide an overview of the Telehealth Making Sense of Brain Tumour program, and just briefly allude to the background research that contributed to the research. So this is an overview of my research over the last 16 years in the area of brain Tumor, which really started with pilot research funded by the Cancer Council Queensland, who recognised that people with brain tumour have unique and differing needs from people with other types of cancer. And they also recognised that they were receiving a disproportionately high number of phone calls in their helpline from individuals and family members. So they provided some funding that helped us to identify unmet support needs, and that led to the development of the Making Sense of Brain Tumour program. And I'm just going to provide a brief overview of how that program has evolved to the current program that's being supported by the Brains program. So this early research, we conducted 30 interviews with people with brain tumour and family members, and our interviews identified two main areas of unmet support. The first was access to information about their particular brain tumour and also support options. And the second was psychological support and counselling for themselves and family members. And a main theme that came out of these interviews was the sense that people were really struggling to understand the effects of their diagnosis and its impact on everyday life, as well as what the future held for them. So this research really provided the foundation for the development of our program, which is a psychotherapy and a rehabilitation program. And it's based on the sense of coherence framework, which is a framework that highlights that for all of us, the ability to understand what's happening to us, the ability to manage what's happening and find meaning in our life situation is really core to our health and well-being. And this is even more so when you have a chronic and potentially terminal illness. So it was really the tenets of this framework that underpinned our focus in the intervention, which is about helping people to understand, manage and find meaning in their life situation with brain tumour. So over a 3-year period, we conducted a randomised controlled trial involving the 10-session Making Sense of Brain Tumour program, which focused primarily on individuals with brain tumour, but we encouraged family members' involvement as much as possible. We didn't want any barriers to people taking part, so we delivered this intervention in people's own homes. So our therapists went out on the road, and I was just reflecting the other day that the Brisbane floods occurred right in the middle of our intervention, and I'll just never forget our therapists jumping in cars hoping that they'd be able to drive over roads to reach people. So for a significant cohort, there was a big impact of the Brisbane floods during this intervention as well. So because it was the first ever psychological intervention for people with brain tumour, we decided to use a waitlist control design. So we allocated people either immediately to the face-to-face intervention or a waitlist, and then people were reassessed and offered the intervention. We then did a 6-month follow-up. So we were able to recruit 50 people, and I'll tell you a little bit more about them in a minute, but just firstly to explain the approach. It's hard to do this briefly, but it's basically individualised psychotherapy as well as cognitive rehabilitation, and it is tailored to people's goals, concerns and the involvement of their family, which meant that for many people the 10 sessions involved a combination of the individual only, caregiver only and couple or family-based sessions. And just the dot points here outline some of the main goals that people had coming in. So there was very much a big focus on understanding and management, learning coping skills and how to manage low mood, support to plan for the future and make decisions, support for family regarding their fears and concerns, a real focus on couple relationship functioning, and also legacy making, which is part of helping people plan for the future. So 50 people were allocated, and a total of 44 people finished the program. So whether this was when they were allocated immediately to the intervention or them taking up the program after the waitlist period. So 44 completed the program, which we thought was quite good for a 10-session program. And then we were able to follow up with 36 people 6 months after the intervention. So our key findings were that controlling for baseline function, there was significant difference in favour of the intervention on depression, existential wellbeing and global quality of life. We didn't get significant differences for anxiety and stress or social functioning. And I think for anxiety, part of the issue was we used the DAS anxiety scale, and I wouldn't use that again because there are too many musculoskeletal and somatic symptoms, which could very much be a result of the tumour itself. So we wouldn't be using that measure again. At the 6-month follow-up, we were really pleasantly surprised to see that people still demonstrated significantly lower depression and stress this time, as well as better existential wellbeing and quality of life relative to their pre-intervention functioning. A really important finding was that outcomes didn't differ according to tumour type. So there was a big question there about whether people with benign tumours would be firstly more likely to take part and complete the intervention, and whether they would derive greater benefits. This wasn't the case. And interestingly, family members, so 60% of programs involved a family member, and their involvement varied from a single session through to all 10 sessions. And we looked at whether level of family involvement or simply the presence or absence of family involvement was significant, and not number of sessions, but just whether a family member attended a single session or not was related to lower levels of depression and better family and social wellbeing at the post-assessment. Of course, this program delivered in people's homes, it's a bit of a Rolls Royce in the sense that we'd love to be able to continue to provide this to people, but, you know, and there are many barriers to people accessing therapy, which is why we delivered it in the home in the first place. But it's a very expensive model of support. And rather than just shifting it to a hospital or a clinic, we recognised that we needed to look at remote delivery or flexible delivery modes, so that people were able to receive therapy and support in the comfort of their own homes rather than needing to travel. But at the same time, that can also pose a barrier. So we assume that people can just use video conferencing or telehealth platforms. This was well before COVID, where people weren't as familiar. So we recognise that people may experience difficulties with telehealth, as we sometimes do as well, such as me forgetting to put my audio on, and that people mightn't feel as comfortable with this platform as they do in person. So we decided that we would trial some telehealth interventions, and I was very interested in Helen's fantastic results for her caregiver website, because I had noted some online kind of more self-guided programs for brain tumour led by the Netherlands, and found that these have actually had quite low uptake and adherence. So I think that obviously you're designing something that engages people more effectively in the website, which is terrific. So our initial focus was traditional telephone, where we just conducted 4 case studies with people living well outside the Brisbane area who we wouldn't have been able to involve otherwise. And they all completed the 10-session program with minimal appointment scheduling. So I remember one woman who'd actually had a seizure the same day was still able to attend the telephone-based support, whereas I imagine she would have cancelled if she'd had to travel. So they reported good therapeutic alliance, and there was initial efficacy for improving mental health, but 2 of the 4 did say that they felt that they weren't as connected with the therapist because they couldn't see her face. So we then moved on to a telehealth intervention involving video conferencing with 14 people with glioma in an earlier stage of diagnosis. So because it was a telehealth platform that people weren't familiar with, it wasn't Zoom, it was actually delivered through the Hospital Queensland Health Telehealth portal. We spent a session training people how to use the portal and covering all the questions and concerns, ensuring that they were confident before they attended their first therapy session. So in this pilot intervention, we had 8 people allocated to telehealth and 6 to standard care. And then after standard care, 2 went on to the telehealth intervention. So of the 10 that undertook the program, 8 completed at least 8 sessions. 1 passed away, and one person resumed full-time work. We did find that most encountered technology problems, and that was particularly problematic for 2 individuals who kept losing audio and visual throughout. Despite this, though, therapy alliance was consistently high, and 5 of the 8 individuals demonstrated clinically reliable change on at least 2 outcome measures. But we've probably got the most information from interviewing people and asking them about their experiences, and these were largely positive. So they emphasised the benefits of the ease of access, being able to stay in the comfort and convenience of their own home. They liked how the program was tailored according to their goals and support preferences, and they also liked the weekly sessions, and that provided a sense of immediacy, because a lot can happen in the life of someone with brain cancer over 10 weeks. And we had people with scans receiving news that their tumour had progressed to a higher grade. So we're able to really be there for them during some fairly critical, stressful times. And then the final theme was really about this sense of connection versus disconnection, and that mainly related to technology, where a sense of connection with the therapist wasn't as good if they frequently lost connection, which is not surprising. So that pilot study was really the precursor to a large ongoing trial that we're running in Queensland at the moment, which is coming to an end very soon, actually. So an NHMRC partnership grant. So I'll just give you a very quick overview of our progress to date. So since October 2018, we've had 186 people make inquiries about the program. Of these, we've assessed 182 for eligibility and found that 56 were not eligible for a mixture of reasons, but one of the best reasons was that people weren't demonstrating significant levels of distress on the distress thermometer. So of the 107 eligible, 26 have declined, which equates to a 76% accrual, which is a little bit higher than some other telehealth interventions for brain tumour, but a bit lower than accrual for in the general cancer population. We've allocated, I believe it's actually now 83, the numbers have popped up in the last day, 81 participants, and we've managed to retain 84% at post-intervention, indicating that they completed the 10 sessions, and then 77% at 6-week follow-up. Interestingly, the comparison arm is the Cancer Council Queensland Standard Counselling Program, which is a 5-session telephone-based support program. So 54% after completing standard care have gone on to the telehealth intervention, indicating the desire for more ongoing, specialised psychological support for brain tumour. So most importantly, what's in store in the future? So the MRFF Brains program is enabling us to really extend our focus well beyond Queensland. And because I wanted to understand really the landscape of psychosocial support outside Queensland, we've started with a national study on psychological support pathways for the brain tumour population. And this is an online survey and an interview study. And Kasia will be speaking next, and she'll be providing some preliminary findings on our online survey in terms of the different support provided by disciplines involved at different time points in the illness. But really, our next focus beyond that is the nationwide implementation of our Tele-MAST program, whereby we will be able to receive referrals from anywhere in Australia, as long as people have access to an appropriate device. So we're including adults with primary brain tumour and or family caregivers. So we've decided to not just have the primary focus on people with brain tumour, whereby in the past, the person with brain tumour needed to take part for a family member to also be involved, but we've decided for this program that we're going to open this up to family caregivers only if the person with brain tumour doesn't want to take part. So we're really trying to make the program more flexible, and then obviously that would have a focus just on the family caregivers' wellbeing. But we will be screening for distress and unmet needs using the portal and people's access to a device. So the focus of this implementation study isn't so much efficacy, because we've done that research. It's more examining factors influencing the uptake of our program in practice from the perspectives of the individual, caregivers and health professionals, so that we can identify some of the barriers that might impede use of the program in the longer term. But what's come out of the survey study, and I actually thought I'd be talking after Kasia, so apologies for flagging this. Another area of interest of mine is training of health professional programs in the delivery of the Tele-MAST intervention, because it's quite clear from the survey that psychologists and other mental health professions don't always feel confident and able to support people with brain tumour and don't have that particular knowledge and skills. So that's going to be a further component that we hope that we can focus on. But yes, I just want to thank you for the opportunity and acknowledge Haryana's support with the entire Brains program, and finish by acknowledging my wonderful team behind me throughout this last 16 years and moving forward. Thank you very much.
Thanks, Tamara, and my apologies for the mix-up about the timing. I think that's entirely my fault.
Worked well.
So I think that's been a fantastic, speed through 16 years of work, and it just kind of goes to, points to the effort and the time that is required to really develop effective interventions. And I guess my question to you is, what would you do differently based on where you are now?
Well, it would have been nice to have programs focusing on the caregiver only. So when we made that initial decision about the primary focus being on the person with brain tumour, it meant that caregivers' involvement tended to still focus on the person. And even though we've managed to have some sessions that was just about the caregiver and how they were coping, it's clear that that really wasn't sufficient. So what I didn't mention is that we did look at some outcomes for caregivers, and we didn't get significant benefits in terms of distress and quality of life. And perhaps that echoes, that earlier intervention, because I think the caregivers do have, they have intertwined needs, but they also have separate and distinct needs. And I think that they need to be able to speak openly and freely about their own needs rather than just how they're supporting the person. So I think it would have been ideal earlier to have another arm of our intervention program, which is still making sense of brain tumour, but it's from the perspective and dedicated to the support needs of caregivers.
Fantastic, thank you. And a quick question from Helen. Are you still delivering telehealth from the PA Telehealth Centre?
No, thanks, Helen. So that was just for that pilot study. It was actually a requirement because we were funded by the hospital, and they don't accept other platforms through Queensland Health. But no, we're using Zoom. We've used Zoom for our NHMRC partnership and moving forward.
Right. So thank you, Tamara. I think we might now move on to Kasha. As Tamara's already highlighted, Kasha's a research fellow at the Menzies Health Institute, Queensland at Griffith University, and her research expertise covers the aspects of improving quality of life care and reducing the level of stigmatisation among people diagnosed with dementia. Her PhD investigated stigmatisation in dementia across Europe, and she has completed a master's degree in psychology in Poland and a postgraduate course in neuropsychology. And Kasha has joined the Brains team and will be speaking today about psychosocial support services available to Australians with brain cancer. So welcome, Kasha.
Thank you, Harry, and welcome everyone. I'm really grateful for the opportunity to present our survey results today. So thank you, Tamara, for bringing me on board to the Brains program and the opportunity to be part of this wonderful group, and also learning about brain cancer, people living with brain cancer and their caregivers. So as Tamara already mentioned, we started, of course I forgot. I want to extend my acknowledgement of country to the traditional custodians of the land on which we all are meeting today, and pay my respect to all elders past and present, and extend that respect to all Aboriginal and Torres Strait Islander people. So as Tamara already mentioned in her quick presentation previously, we wanted to see how people with brain tumor are psychologically supported across Australia. We know that primary brain tumor is a rare yet serious illness that has combined effects of cancer and brain injury. And people with brain tumor typically experience physical, cognitive, emotional, and behavioral effects, which are related not just to the tumor itself, but quite often also to its treatment. And we know, even after those 10 years since Tamara's first study looking into psychological unmet needs among people with brain tumors and their carers, that there is still limited understanding of the clinical pathways and options for accessing psychological support in Australia. So our objective across the survey, which I'm presenting now, and also the second part, which are in-depth interviews with health professionals, we wanted to scope the current practices of professionals who are involved in some way in providing psychological support and supportive care to adults with brain tumor. As we also acknowledge that it's not just clinical psychologists and neuropsychologists who are involved in providing supportive care to people with brain tumor, and professionals across disciplines like social work, nurses, medical oncologists, and other allied health professionals are also involved in this care. So we wanted to hear them in our survey and then in our interviews, how they see their current access to psychological help, and also how they provide the supportive care to adults with brain tumor and their family members. So we ran an online survey, which was available at the Griffith University Research Survey tool between April and August 2021. The survey consisted of 29 questions, which were related to the demographic characteristics, work experience, and clinical settings. We asked about the nature of psychological support and supportive care which was provided to adults with brain tumor and their family members by the health professionals. We also asked about the types of assessments and interventions they conducted with adults with brain tumor. And we also asked one open question about perceived barriers and gaps in the provision of psychological support. Who was eligible to take part in our survey? Any health professionals who is currently involved in providing psychological support to people with brain tumor in Australia, regardless of the frequency of the contact with people with brain tumor. And it was not limited to any professionals. The recruitment, we asked people from our network to fill the survey and circulated to members of psychology, oncology, brain injury, and neuropsychology professional membership bodies. As an example, PoCoG played a big role in helping us to reach our participants. So out of 135 people who initiated the survey, 107 completed adequate sections of the survey, which was the first 18 questions. Majority of our participants were women. They represented all states in territories across Australia. Over 75% worked within only with adults with brain tumor, and they represented working with different client populations across cancer, brain injury, end-of-life care, working with people with chronic health conditions or mental health. Across disciplines, majority of our participants were from psychology or neuropsychology. We also had a big group of nurses and social workers who completed our survey. Among others who completed the survey, there were medical professionals like radiation oncologists. We also had a person who is providing a peer support for other people with brain tumor. Our main question in the survey was regarding the frequency of practice. So how often the practitioners who completed our survey screened for psychological distress, cognitive problems, how often they provided psychological support to people with brain tumor or to their family members. So as you can see, 65% of people who responded to our survey provided some screening for psychological distress between sometimes to always when they meet with the person with brain tumor. However, the cognitive assessment was usually performed never or rarely by 67 health professionals. What's interesting, majority of our participants, over 81%, provided some form of support sessions. They were not just psychologists, other representatives of other disciplines also recognize that within their practice, they're providing psychological support. And the last one about supporting family members, over 71% of people who completed our survey provided some form of support to family members between sometimes to always during the contact with them. We also looked at the differences across the groups of different professionals. So psychologists and nurses are more likely to screen for psychological distress than social workers. Surprisingly, psychologists are less likely to provide support for families than nurses. As Tamara mentioned in her speech previously, psychological support was more typically provided in the long-term management phase than early post-treatment. And interestingly, we noticed that those professionals who are working with people with brain tumor between 6 and 15 years across their practice are more likely to provide psychological support comparing to those with less or more experience. In the last question, the open one about perceived barriers and gaps, we received 76 individual responses here. And the main themes we identified were related to the lack of specialists trained in brain tumor area. This is what Tamara already mentioned in her presentation. Also, they identified lack of support available to family members, including children of adults diagnosed with brain tumor. The barrier is also a lot of time constraints among those professionals who are working in other disciplines than psychology. Also wait lists. It's difficult for people with a brain tumor or their family members to receive a timely psychological help quite often. And also there are barriers in accessing support within the community. Either they are expensive or the service can be limited, like in the remote areas, but there is also lack of very limited awareness of available services where people can receive help. So the provision of psychological support for people with brain tumor varies across disciplines and management phase of a brain tumor. There is a great need for better access to psychological support, especially early during the treatment and early post-treatment. And there is a need for brain tumor specific training for professionals. What are the other steps we are undertaking? We are currently finalizing the second part of the study, in-depth interviews with professionals working with adults with brain tumor, which allows us to hear a bit more about how people support people with brain tumor and their families, to really hear about their experiences, as our survey was not able to cover all those aspects. So we expect the results of our interviews around mid-2022. I want to say thank you for the opportunity to present this study, and I'm leaving the contact details in case there are any questions.
Great. Thank you very much, Kasia. Really fantastic to see this data. Faris, which is, did you see differences between the states in the results?
We were looking at them, but no, we didn't see differences between the states. As you could see in our presentation, some of the states we really had across, we covered all the states. However, representatives on some of the states were really low. So maybe if we could see more answers from different states, those differences could be visible, but according to our group, no. However, in our interviews we are conducting now, when we look into in-depth procedures and clinical pathways, there is a chance we will be able to report on some differences.
Okay, great. And I think we might stop there in the interest of time, and thank you again for your presentation, and look forward to the more in-depth qualitative results as they emerge over the next few months. And we'll move on now to welcome Dr. Karen Pike and Sian Virtue Griffiths, who are going to be presenting to us about the LATCH program, so developing a memory training program for brain cancer survivors. So Karen is a senior research fellow and registered neuropsychologist in the School of Psychology and Public Health at La Trobe University, and she has a particular interest in her research on neuropsychological and biomarker characteristics for preclinical Alzheimer's disease and interventions to improve cognition and therefore the lives of people with memory concerns or difficulties. So I will now stop talking and hand over to Karen and Sian. And Karen, if you're talking, yes. Unmute. Yes.
Yes. Can you hear me now, Harry? Oh, good. Okay. I assume everyone can hear me and see the screen. So thank you so much for inviting us along to speak today about the memory training program that we've been developing for brain cancer survivors. So as Harry said, so I'm going to start off and talk a bit about how this program's developed from my work with older adults, and then about halfway through I'm going to hand over to Sian to talk about what we're doing as part of the BRAINS program. So I think on this first slide I'll just give a little bit of a background in terms of as Harry was mentioning, you know, I've mostly been working in preclinical characterisation of Alzheimer's disease and so forth. And so, you know, how do we get to cancer? So a lot of my work has been looking at older adults with cognitive impairments, mostly around their memory, and then what can we do to help them? And so a lot of that has been in terms of developing some memory programs and group memory programs to help older adults. And while I was doing some of this work, I came across that, you know, people with cancer survivors often have report cognitive changes as well. And so you can see, I mean, here particularly, I'm probably not telling anybody anything new here, but, you know, almost all brain cancer survivors have some reports of changes with their cognition and memory, so their memory and thinking. And it's an important area to look at because this really impacts people's everyday function and quality of life. And we do know that there's stuff we can do to help. So there's research literature showing that cognitive interventions, particularly around compensatory strategies and a cognitive rehabilitation type of approach, is helpful for adults with brain cancer. But even though we've got that in the research, it's, you know, it's very difficult for people to access any of that kind of support in Australia. There's very few clinical services that are able to offer cognitive interventions for people. So it felt like, so sitting over in older adult world, looking over here what was reported in the cancer world, it felt like there was a bit of a gap. Yeah, that's fine. Next slide if you want, Sian. And so I wondered, we've been developing this LATCH program for older adults. We've done RCTs, and I'm going to show you that data today. And I thought maybe this is a good fit for cancer survivors as well. So I thought I'd go through a bit about what LATCH is, and some of the research in older adults, and then we've done a little pilot in cancer, and then Sian will tell you what we're going to do with the brain cancer survivors as part of the MRFF a bit later. So LATCH it's initially a memory management strategies program. So it's about improving your memory in everyday life. It's a 6-week program, traditionally face-to-face, with about 6 to 12 people in the room. You know, they come along to the room for 2 hours every week. There's a couple of facilitators, who are well trained in delivering this sort of information, who run the program, but it's very much an interactive group. The facilitators provide psychoeducation about how memory works and how we expect it to change with aging and what we can do about it. But it's very interactive problem-solving approach about the participants bringing along their issues with memory and sort of working through different strategies to help deal with that. It's manualised, so there's certain topics that are covered each week. But, there's possibility there for some individualised work. It's a CBT approach. It's, I want to emphasise, although it focuses on memory strategy training and what you can do in a practical sense about practical strategies for everyday life, there's also a large component of it that is about, that's a psychological component that's supporting people in how they perceive their memory and cognition and helping sort of normalise, depending on their situation, that, lots of other older adults have these kinds of issues. And in the cancer situation, lots of other people with brain cancer experience similar issues to you. This isn't actually unusual. It's kind of par for course. Okay. Yep. So I think next slide. Thanks, Sian. And then in terms of the content, so it's very much focused on everyday kind of problems people have. So each week we have a different topic that I hope if you look at those, they sound like the memory problems everybody here probably has most often as well. So, you know, forgetting names, forgetting where you've put things, trying to remember your appointments, those very kind of common topics that most people report. And then there's sort of a set of strategies that often overlap for lots of topics. So we come back to the same strategies quite often, and that tend to be about, so first teaching people about understanding memory and how it works, and getting some reasonable expectations about what you should and shouldn't be able to remember. Understanding what's impacting memory. So, you know, in our normal aging, that's about normal aging versus dementia, but in the cancer group, it's more about the various aspects of cancer that might be impacting on your memory and thinking. And then the sorts of strategies we talk about, first it's about things like preparing for remembering. So being confident about remembering things and remembering to concentrate if you do want to remember something. You know, if you don't get something into memory to start off with, you're not going to remember it. As much as possible, reducing your memory load. So if you don't need to remember it, don't use it. You know, write a note, do tasks straight away, be a bit more organised. And then we train people in specific internal sort of strategies that work. Okay, next slide. Yeah. And so here's just the papers. So in the older adult group, we've published, we've done a big RCT, and we've published studies to demonstrate that that works. And I think the results are on the next slide from the RCT. Yeah. So here's the findings in older adults. You can see we had big sample size, about 100 people in each group. It was a waitlist RCT. We found that for both healthy older adults and for older adults with significant memory problems with mild cognitive impairment, the latch group improves their knowledge about what strategies they could use in different situations. It improves their use of strategies in different situations, and it improves how they feel about their memory. They're less worried that they're getting dementia every time they have a memory slip. We also did some qualitative work with our doctoral student, Melinda Matthews. And in that work, it sort of focused, that allowed us to look at some of the aspects of a group program that are hard to measure by a questionnaire. And when Melinda went back 5 years later and asked people what were the most significant changes, people are finding that they're more likely to be accepting their memory and where they're at. They really get a lot out of the shared experience of being with other people who are sharing similar experiences and can report different sort of strategies to solve their problems. And we also found that carers, particularly for people with MCI, actually had reduced stress from their person being involved in much. So that's in older adults. So I think then we're going along to the cancer trial, aren't we? Yeah. Oh no. So quickly before that, so that was in older adults, and then traditionally it's face-to-face. During COVID, we couldn't run groups face-to-face, and we did do a quick telehealth pilot. I didn't want to say much about this, but just to flag that we've done this, and it was feasible as long as we screened the participants and made sure that they were reasonably tech savvy. So I think then the next, and it gave us the same kinds of results and things as we find in the face-to-face group. We were actually really happy that we managed to still create the connection with the 4 participants who did telehealth latch. We were a bit worried we weren't going to be able to, but people got the same psychological kind of things out of it as we see in the face-to-face groups. So then the same time, also actually slightly earlier, we got some money. As I said, I was sort of interested in, you know, how this might relate over to people with cancer. And so with colleagues at Austin Health at the O&J Centre, we actually got a little bit of funding from NEMICS. And in 2019, we ran a pilot trial of face-to-face latch for cancer survivors at NEMICS. Originally, we were just going to have brain cancer survivors, but we had struggled to recruit enough people in the time period to attend groups. So we had 10 adult cancer survivors in total, and half of those were brain cancer survivors. So we had mixed groups. And we found, look, it worked really well. People got their goals about memory improved. They felt better about their memory. They reported using more strategies, and they perceived their cognitive impairment improved. And there's quite large effect sizes, of course, small groups, but large effect sizes. And they also reported changes in their emotional well-being, particularly depression decreased a bit, and their emotional well-being on the improved, not FACT-COG. Yeah, great. So it seems like it's a really promising intervention, but as I mentioned, we had trouble recruiting sufficient brain cancer survivors at one site. So that's kind of where the MRFF comes in, where we've thought about maybe what we'll do now is go nationally. So we've got multiple sites, and we might also have a look at a telehealth method to reach more people. So I think, Sian, I'm going to hand over to you to talk about the next little bit.
Yep, great. Thanks, Karen. So that sort of really nicely sets up where Latch is at currently, where we're wanting to determine whether we can see this efficacy in a group of brain cancer survivors specifically. And what we're doing now is we're developing Latch as a RCT within this hybrid implementation design, so that at the end of Latch, at the end of the trial, hopefully Latch is either already implemented or well on the way to being implemented. How the hybrid implementation component looks within the RCT is, alongside running the interventions, we're also incorporating implementation measures to try and identify the barriers and the facilitators of implementing Latch within the community at the end of the trial. The way we're doing this is adopting this sort of three-armed approach that you can see on the slide here. So firstly, what we wanted to do was get input from the brain cancer survivors who completed Latch at the Austin and get their advice on anything that they thought was particularly suitable or not suitable for brain cancer specifically from the content of Latch. We're also holding brain cancer care coordinator focus groups to get their input on not only the content of Latch, but also any suggestions for the best recruitment avenues and also the best ways in which we can incorporate and implement Latch in the community. And the results from these two arms are going to be fed into the setup of Latch at the intervention. So we've managed to have interviews with 3 of the brain cancer survivors who completed Latch at the Austin, and we haven't conducted any formal analyses on this information, on this data yet, but there were commonalities that came out across all participants essentially. So they all said that the group dynamic was really important, and that, as Karen said, that helped to really instill this sense of a shared experience and normalize those cognitive changes that they were experiencing following brain cancer. And they flagged that it would be really important to make sure that's maintained in this online telehealth format that we're adopting. They also indicated to us that the recruitment occurring through their brain cancer care coordinators at Austin actually gave a sense of legitimacy and credence to participating in the Latch intervention. And another interesting consideration that they told us about, and was common across all 3, was that although the cognitive strategies were quite useful, they really found the content on the psychological contributions to changes to cognition particularly helpful, and something they would have liked to see a little bit more of a focus on. So some really interesting and useful information that's come out already from these interviews that we've held. Moving on to the focus groups with the brain cancer care coordinators. So currently we've identified 16 individuals working in care coordinator roles throughout Australia. This is very much a working list, and so we're looking to update it because, as you'll notice, we actually don't have anyone from South Australia, Tasmania or the Northern Territory. So if anyone out there is a care coordinator or knows of a care coordinator who might be interested in attending these focus groups, we'd love to hear from you. So please reach out to either Karen or myself. The content that we cover in the focus group sessions is, firstly, we wanted to get an understanding of the cognitive concerns that brain cancer survivors actually coming to their care coordinators with. We also wanted to get the care coordinator's opinion on the suitability of the content of Latch for the brain cancer survivors they work with, and also the suitability of participating in the RCT for those brain cancer survivors. And finally, we wanted to know if they had any suggestions for the best way to recruit, given we're trying to recruit Australia-wide, and any sort of information they could provide about the best context in which to implement Latch within the community at the end of the trial. And that brings us finally to the actual intervention itself. So what we're aiming to do is to recruit 50 brain cancer survivors, and the RCT is waitlist controlled. So the waitlist group will commence the intervention once their respective intervention group has completed the booster session and also the assessment across the post measures. So we're aiming to have around about 4 to 6 people in each group to try and maintain that group dynamic, but to also not make it too large across Zoom. We're also incorporating another aspect of implementation within the running of the sessions. So not only will the facilitators be members of the research team like Karen and myself, we're also looking for appropriate health professionals who are interested in being trained to become a facilitator of Latch. So not only brain cancer coordinators, anyone really working in that brain cancer field, so occupational therapists, speech pathologists, we would love to hear from you. And really the idea of that is to try and optimize this take up of Latch in the community once the RCT has been completed. We're starting recruitment in February. And so hopefully we'll be presenting sometime next year with some fantastic results and some great efficacy and implementation news. But that is the end of it for us. Thank you so much for listening, and thanks for the opportunity to present here today.
Great. Thank you so much, Sian and Karen. Great to hear about that. There is one question from Vanessa Burrett in the regarding the potential suitability for the Latch program for patients beyond brain tumours. So whether it's suitable for people who may have cancer-related cognitive impairment as well. Do you want to comment on that, either Sian or Karen?
Yeah, no, I can comment on that. Thank you very much for the question. Yes, I think it is. So when we did the little pilot, the Austin, that was a mixed group. So as I said, there was 50% brain cancer survivors, but we had a group of people with hematological cancers and I think some breast cancer survivors and things as well. But it seemed to be a good intervention, you know, for people kind of regardless of the underlying cause of their cognitive related cancer impairment. Yeah.
Okay, brilliant. And a question from Julia Robertson about whether or not you're going to be using closed captioning in the Zoom sessions to increase accessibility.
Yeah, we haven't thought about that, but that's probably a really good suggestion. So yes, the answer will be yes.
Fantastic. Awesome. Well, thank you. We might just move on in the interest of time, but really excited to see that study get started. And it's now my pleasure. I'm going to change the order slightly and introduce Dr. Rachel Campbell, who is a research fellow at the University of Sydney, who is working on the BRAINS program as a postdoc. And Rachel has a background in psychometrics and has a particular interest in fatigue in relation to health, chronic health conditions. And Rachel is going to be speaking to us now about online interventions to increase self-efficacy to self-manage fatigue, for fatigue in people with brain cancer. So welcome, Rachel.
Thank you very much, Harry, for the introduction. So just checking you can see my screen and hear me. Okay, perfect. Okay, so hello everyone. So as Harry has explained, today I'll be presenting on our planned research, which is still in its preliminary stages. And we are planning to examine whether an online intervention to increase self-efficacy to self-manage fatigue can help people with brain cancer. So cancer-related fatigue is an extremely common and distressing symptom in people with high-grade gliomas. Between 89 to 94% of people with high-grade glioma report cancer-related fatigue, and 39% with low-grade gliomas report cancer-related fatigue for up to 8 years post-treatment. So this is, of course, really concerning because cancer-related fatigue can have a very profound impact on people's ability to simply engage in their everyday activities, and it can impair all aspects of quality of life. But unfortunately, it's quite well established that fatigue is often underdiagnosed and undertreated, not just in people living with brain cancer, but also more broadly in general cancer populations. And so Restore is an online web-based intervention that was developed by Claire Foster, who was a researcher based at the University of Southampton in the UK. And Restore was designed specifically to enhance self-efficacy to self-manage fatigue following primary cancer treatment. And a preliminary evaluation of Restore found that it was a feasible intervention, and it also demonstrated initial efficacy in a mixed sample of cancer survivors that were treated with curative intent. And I'll provide a little bit more detail on this evaluation later on in the presentation. And so the objective of our planned research is really to examine whether the Restore intervention could be adapted and whether it is appropriate for use in people with brain cancer. And sort of before I go into our plans in more detail, I'll just start by providing an overview of the original development, content, and preliminary evaluation of the Restore intervention. So the development of the Restore intervention was informed by the Medical Research Council's guidelines on developing complex interventions, and it involved a comprehensive 9-step process that you can see summarized here on this slide. So this included a review of empirical literature on cancer-related fatigue, as well as a review of existing patient resources. It also included the establishment of a theoretical framework and a design team that included people with expertise in web-based interventions, as well as expertise in cancer-related fatigue and people who were affected by cancer. And so following these first 4 steps, there was an initial prototype of the intervention developed, and this then underwent user testing. It was then further refined and underwent user testing a second time, which then resulted in further refinement of a prototype that was then ready for testing in an exploratory randomized controlled trial. So if you're interested in learning more about this process in detail, then the development or a description of the development of the Restore intervention has been published. So you can see the publication details here on this slide. So this is what the Restore web-based interface looks like. And the intervention itself consists of 5 sessions, and these sessions are completed weekly, and each session takes approximately 30 minutes to complete. So sessions 1 and 2 are core modules, and they're completed in the first 2 weeks. And participants can then choose from sessions 3 to 5 for the final 3 weeks. And so, for example, with this, each participant could choose to visit the same session 3 times, or they could choose to visit each of the 3 remaining sessions once. So in terms of the content of the Restore intervention, the first session is a core introductory module, and it covers what fatigue is, as well as the effects and causes of fatigue. And it also includes video clips and patient narratives about coping with fatigue. The second session is another core module, and it focuses on goal setting, and it introduces the concept of self-monitoring, goal setting and planning, and SMART goals. Session 3 focuses on diet, sleep, exercise, home life, and work, and it describes how fatigue impacts on these aspects of everyday life and how effective goal setting can help to manage this interference. Session 4 focuses on managing thoughts and feelings, and it describes the psychological aspects of fatigue and how these can be managed, including through goal setting. And session 5 focuses on talking to others, and it describes the difficulties of talking to others about fatigue, and it provides some strategies to help manage this through goal setting. And throughout the Restore program, there are a number of structured activities that are available, and these focus on goal setting and automated tailored feedback on the achievement of goals. And participants are also encouraged to download and complete a fatigue diary that's also provided through the program. And so a preliminary evaluation of Restore was conducted in a multi-center parallel group 2-armed exploratory randomized controlled trial. And this also included a qualitative process evaluation. And so participants in this randomized controlled trial were randomized to either the Restore intervention or to receive an educational leaflet on cancer-related fatigue. The participants were eligible for inclusion if they were adults older than 18 years of age, if they were less than 5 years post-treatment, and if they self-reported moderate to severe fatigue. And so 163 mixed cancer survivors participated in this RCT. And the results indicated that the intervention was feasible, with 39% of eligible participants consenting to participation. And it was also deemed to be acceptable with a 36% attrition rate. And in addition, in the intervention arm, participants reported an increased self-efficacy to self-managed fatigue 6 weeks post-intervention compared to the comparator group that received the leaflet on cancer-related fatigue. So to date, this is the only evaluation of Restore that has been conducted, and the Restore intervention is now publicly available. So if you're interested in having a look at it, you can see the link to the intervention provided there on the bottom of the screen. And so the work that we are planning to do as part of the BRAINS program will be conducted in 3 phases. So in the first phase, we are planning to explore whether the Restore intervention is appropriate for people with brain cancer, and also what modifications or adaptations are required to tailor suitability. And so we plan to do this by guiding brain cancer care coordinators through the Restore program and then eliciting their feedback on the program through qualitative interviews. And then based on these phase 1 findings, we then plan to create a modified version of Restore, which we'll pilot test in a single arm feasibility study. And so we'll then determine the feasibility and acceptability of this adapted version of Restore for people with brain cancer. And then finally, in phase 3, if phase 1 and 2 prove to be successful, then we will implement a referral pathway to the adapted version of Restore into the BRAINS unmet needs and screening platform that Joe described earlier. And the efficacy of the adapted version of Restore will then be further evaluated as part of this process. So this work is still in its very, very early stages. We are at this stage still working on the protocol and the ethics application for phase 1. So we still have quite a lot of work ahead of us, but this is just an overview of what our plans are. So thank you very much for listening, and I look forward to answering any questions that you have.
Fantastic. So thank you, Rachel. And just quickly, I think you've given us a really nice overview of where to from here, and I guess we'll be in touch with various people, particularly care coordinators, around potential participation in that first stage of the study. As we're about to run out of time, I'm just going to move on and present for us on behalf of us, Dr. Ursula Sanson-Daly, about the Recapture Life program. And I'm just going to, okay, can you see those slides okay? I'll just put it.
Yes.
Excellent. Okay, so this is the Recapture Life program for brain cancer, which is being led by Ursula, as I said. And what it's doing is building on some work that has already been done again. So we know that in the adolescent, young adult years, this is a particularly important time for the onset or a potential time for onset of mental health disorders. And there are interventions that are able to address those conditions before they become established, or to deal with them once they have developed. So this has been particularly explored in the area of the adolescent young adult cancer survivorship population, where Ursula and her team have developed multi-session skills-based interventions, particularly focusing on cognitive behaviour therapy, and explored the feasibility and efficacy of these interventions over a number of different projects and years. Based on the development of these interventions that were originally face-to-face, Ursula has gone on to develop Recapture Life, which is a CBT-based video conference intervention for AYAs in the survivorship phase of cancer. And what we are doing within the BRAINS program is, and what they've done so far is to have done a evaluated Recapture Life in a 3-arm randomised controlled trial, and then also gone on to develop, to conduct an implementation and effectiveness study looking at delivering Recapture Life in a community organisation setting. So what we will do within the BRAINS program is to adapt Recapture Life to address the needs of adolescent, young adult cancer survivors, brain cancer survivors, and explore that in detail. One of the things that we are doing is expanding the definition of AYA from the upper limit of 25 years of age to 40 years of age. And we think that there will certainly be some important and interesting adaptations that will need to happen based on individual stages of life as we go through that process. So what are we currently doing? Ursula's little team has been very productive. Ursula is currently on parental leave, as is Jessica Buster, her PhD student. But what they have been doing and will continue to do is to develop Recapture Life for brain cancer as part of Jessica's PhD work. And in the interim time, the research officer, Gadiel Dumoulin, is conducting interviews with previous participants from Recapture Life and has so far completed 7 interviews with 7 of those participants to guide the development of the brain cancer components. Sorry, I'll just skip forward there. And so that really brings us to the end of where we're going. So there is again going to be a lot more a lot more development work that is being undertaken as part of that program. And we will again be really excited to see that being rolled out and made available for individuals. And so with that, I might draw our session to a close, and thank you all for your participation. In particular, thank you very much to our speakers who have all presented really important updates on the work that we're undertaking, and hopefully many of you in the audience will be engaged in as we go forward over time. So thank you again, and thank you for joining, and please do share the YouTube video, YouTube channel links so that other people who are interested may access this later. So thank you all. Thanks for joining. Bye. Bye.